Good afternoon, and thank you for joining us today. Today we are having the Health Policy and Process and Program Management CPH Exam Review webinar, and we are grateful to have you here and grateful for our wonderful presenter today. Before we get started with the content, I just wanted to go over a couple study resources for you. If you've attended any of these webinars before, this is going to be things you've already heard, so I'll be brief. But the first step that we have, we recommend for participants preparing for the CPH exam is to review the content outline. And I'll touch on that in a second. And all of the resources that I'm going to talk about are going to be available on the nbphe.org/cph-study-resources website. So you can go there and get a link to all of this information. So the first thing is that content outline I was talking about, and that's going to break out the 10 content areas of public health that as a CPH professional you are expected to be well versed in. And within each of these areas are going to be specific job tasks that we had done a job task analysis, and we identified the different aspects of public health professionals that you need to have mastered within each of these content areas. So you can start there and review all of those job tasks within each area. We also have on the NBPHE website a static sample exam questions that you can review, you can look through, you can kind of get a feel for the type of questions you will see on the exam. We also have a static batch of practice exams. It's a mini exam of 50 questions. These are retired questions from the CPH item bank. So again, that'll give you an idea of the type of questions you will be approached with on the actual exam. We also have a couple more webinars coming up. We have the Public Health Biology and Human Disease Risk on September 27th. And then we are wrapping up this webinar series for this fall with evidence-based public health biostatistics focus. And that's always one that scares people, but we're going to have an in-depth detailed biostats review and go over the components of biostats that you'll be expected to know on the exam. Again, there are no calculations on the exam. You're not going to be asked to do any complicated equations, but it's knowing the theory and the modeling of what a biostatistician does. And all these, the ones that I've talked about, the ones coming up, and all the ones that we've done this summer as well as past summers are all on the NBPHE website. And then we have the CPH study guide published by us, ASPPH. And this is not a text-based study guide. This is a bank of practice exam questions that when you go through the CPH study guide on ASPPH, you will be faced with an exam very similar to what you would get actually in the NBPHE certification exam. And that's going to, once you get through, it's going to give you a detailed report on what you got right, what you got wrong. And for all of the questions, there's going to be a detailed explanation as well as resources that you can click on to get further information. And then some of the questions also have a video explanation by a CPH professional expert in that field. And then the last thing that we recommend is the APHA published study guide. And this was written by our fabulous faculty at the University of South Florida College of Public Health. It has a chapter on each of the areas. It has definitions, it goes in depth into the detail of the different components, as well as has a couple of practice exam questions for you. So if you're one that really wants to get down and dirty and get into a text-based form of studying, this is one we definitely recommend. And this you can buy directly from APHA on APHA's website. Just go to their publications and periodicals section. And without further ado, I'll go over a few administrative points and then we'll get started with today's content. If you see on your screen, there'll be an orange box with a white arrow, and if you click on that, that'll extend your control panel. Within that, you will see a questions dialog box, and right there is where we'll ask you if you have any questions as Dr. Pruitt is going through the study materials today. Just go ahead and jot those down. I'm going to be monitoring those questions throughout the presentation, and if there's anything that I need to answer just in general, I will during the presentation, and then afterwards I'll go ahead and pose those questions to Dr. Pruitt, and we can discuss any questions you have in detail. So without further ado, I'd like to introduce Dr. Zachary Pruitt from the University of South Florida College of Public Health. Dr. Pruitt was instrumental on several of the chapters within that book that I just discussed, and he knows his stuff. So he's going to start off with the health policy process, and then the second half of his presentation will be program management. Dr. Pruitt, thank you for joining us today.
Thank you, Erin, and thanks to everybody who joined us today for the webinar. I appreciate it. Sure, I'm Zachary Pruitt. I have a doctorate in public health. My master's is in healthcare administration, so the business of healthcare. And then notably, I'm certified in public health, which means I took the exam. I will say, it wasn't easy, but it was something that I felt afterwards when I took it. Like, I think a competent public health professional could do really well on this exam. I didn't take it cold, certainly. I studied and did note cards and reminded myself, certain biostatistics terms and social and behavioral concepts and theories. And so I did all the studying you're supposed to do, but I, in general, felt it was very fair, and I think you'll find that to be the case as well. So today, I will start by reviewing the health policy process. I teach health policy in addition to management and strategy and some other quality management, those sorts of things. I will give a plug for the Certified in Public Health Exam Review Guide that Erin mentioned. Policy in Public Health is Chapter 9 in that book, and it was written by Barbara Orban and Jacqueline Wiltshire, who are colleagues of mine. And I find the chapter to be pretty in-depth. We won't review each of those, but we will have a few of the session objectives to cover the basis to help you on the exam. So again, to address more objectives, please get books or check out those study guides for more in-depth coverage regarding the health policy process. So for today's session objectives, I want you to be able to develop positions on health issues, laws, and policies. I want you to use scientific evidence, best practices, stakeholder input or public opinion data to inform policy and program decision making. I want you to be able to educate policy decision makers and improve health, social justice, and equity. Mostly today, we're going to discuss the policy making process. The chart here just seems very academic, and for that I apologize, but I tell you, this really simplifies what can be a very complicated process. It's created by Beaufort Longest in his book, Health Policy Making in the United States. And I like it just because it's a 1, 2, 3 step process that is a cycle or iterative process. For me, it's easy to grasp what's going on and how policy gets made, especially in public health. What happens with the policy making process, just as an overview, you have all these external factors going on, such as preferences and individuals and organizations and interest groups and such demographic change or ecological changes or economic issues going on, all these sort of outside influences that are impacting how we view things from the problems and the solutions and how we might implement certain health policies. It goes through 1, 2, 3 steps, starting with the policy formulation phase. Then once legislation happens, it goes into policy implementation, and that policy then is modified through certain factors. And we'll discuss each of the 3, 1, 2, 3, in order as we go through. But before we go through each of these in detail, I want you to think in your head something that's important to you, a public health problem that you would like to see get fixed. And there are lots of those ideas out there. There may be something that you're working on in your day-to-day world that you find that it'd be important to think about as I cite certain examples. I'm health policy. I deal a lot with health insurance and hospitals and clinics and doctors and the roles of managing the health system. but many of you are public health oriented, working in public health agencies, and have certain expertise that you may want to apply to these examples. So think of something in your head. The examples could go on and on. We could spend the whole time talking about public health examples of positions you could take, such as, should we have cars at all, right? Manhattan has that example where they're trying to limit the number of cars that can come on by creating taxes. Well, big in the news these days are these assault weapons, the AR-15, AK-47s. Some suggested banning those or doing a buyback. New York City also had this sugary drinks and trying to regulate the amount of people were drinking these huge sugary drinks. Drowning prevention is something that we'll talk a lot about today. My wife that's one of her issues, and so just recently went to support her in her development of certain policies around drowning prevention. Breastfeeding, supporting mothers at work doing breastfeeding, or maybe doing a needle exchange. These are all examples of problems with potential solutions that you could have in going through this lecture. So keep that in mind. So let's use the drowning prevention one as an example. I said my wife, she's on a nonprofit board, she's a pediatrician, and one of the things that most concerns her is childhood drowning. Not only is it a concern because the number of people killed, but the children who are injured due to this. Drowning ranks the 5th leading cause of unintentional injury in the United States. And about 1 in 5 people who die from drowning are children 14 and younger. For every child who dies from drowning, another 5 receive emergency department care for non-fatal submersion injuries. So think of your example that you had in your mind today. What are the facts? How would you measure the problem and communicate that to your stakeholders? Great. So you have a problem. So in this example, we're using drowning is a big problem. It's a big problem for children. In the policy formulation phase, we have to recognize that there is a problem. And when we do that, then we could then develop possible solutions, understand the political circumstances. And when that happens, there's something called a window of opportunity. And when that presents itself, you can develop legislation that could then pass. Now, the problem has to be met with a possible solution that is implementable, that the constituents, the stakeholders can accept, that can be implemented, and that the political circumstances, that those who support it, the coalitions, and all the things that must line up to create legislation that will pass must happen before it can become legislation. So we'll go to the next step. So we recognize certainly that there's a problem with childhood drowning, and we want to think to ourselves, okay, what are the possible solutions for that? Certainly, teaching swimming skills might be important. Lifeguard CPR training, requiring life jackets and certain boating craft, safety barriers such as fences around the pools. These are possible solutions that we could legislate. But we need a window of opportunity. And oftentimes what happens in the development of public health policy is that a problem is recognized through the evidence in the public. You're doing communication to make everyone, including your stakeholders, the legislators, the regulators, the public, understand the nature and the intensity of the problem. But what must happen is, and also you have to have solutions developed. In other words, you have to think about what is available to us to solve that problem. We have to know what the evidence says about those solutions and its feasibility for implementing. But you also have to have what we call that window of opportunity. When a circumstance comes together, the political circumstance, the problem, and the potential solutions all come together at once to do that. And oftentimes, negative things happen to create a window of opportunity. And in this case, in the state of Florida, where I live, a tragedy happened. Mackenzie Merriam was 18 months old when she slipped away from her mother, and she drowned in the family's pool in January of '98. Preston Iburn was 5 years old, and he slipped away from his mother at a barbecue, hit his head, and he fell into the pool unconscious. So eventually, that bill passed in 2000, and it was called the Preston Iburn Mackenzie Merriam Residential Swimming Pool Safety Act. It was passed into Florida law. It had favorable support from legislators at the time, and political circumstances were such that it could happen. But this tragedy, in addition with the knowledge of the level of the intensity of the problem, in addition to some really viable solutions, created that development of that legislation. The window of opportunity, while a tragedy, allowed the communication to be as such that it compelled the legislature to take action. And we saw that potentially in Obama's administration at the federal level when the Sandy Hook massacre happened, the elementary, and he immediately came out with some gun restrictions to try to limit the assault rifles. And while it did not go anywhere because of the political circumstances, you definitely saw how a window of opportunity could have happened, although it closed based on some blowback from other constituents. But nonetheless, these tragedies or these opportunities create themselves to the development of legislation. Now, remember, legislation happens in the legislature, right? So this is the Congress at the federal level, the House and the Senate, and the same thing at the state level, where you have these elected officials, the House and the Senate, oftentimes bicameral in the states, and they will then pass these laws. But in the state of Florida, it was about safety barriers, and certainly they required those to be put up. And so when those possible solutions were developed, they went out to try to develop legislation. They met with people to say, okay, look, these safety barriers work, and here's what we're going to do. So the next step, when the window of opportunity presented itself, was to create, to inform and advocate. So collect the scientific evidence, describe the best practices, gather stakeholder input, educate policymakers and decision makers to improve health, social justice, and equity. So the message is very clear. So I'll take you through each of these four in turn and try to use as much as possible the drowning prevention example. But I want you to be thinking of your example in your head about how this might work. So first, we gather scientific evidence. We can use lots of sources, the CDC's National Center for Health Certificates, which is health statistics, which is where I found the drowning prevention and the drowning numbers, its relative impact on the Florida youth and the deaths across the nation as well. You could use county health rankings and roadmaps, AHRQ's National Guideline Clearinghouse, and of course there's something called the Cochrane Database of Systematic Reviews, which takes studies across many different authors and combines them to give you an overview of what the scientific consensus says. So those systematic reviews are really important for aggregating the scientific consensus that you can communicate then to your stakeholders. You also want to look for best practices. Certainly the NDPA, National Drowning Prevention Alliance, would have some recommendations about how to prevent drowning. They would have done some additional advocacy and evidence collection that you can use to identify what best practices or solutions might fix your problem. So that would be a good place to start. But as you know, there's lots of coalition partners that can provide you with these best practices. You could also look to other public health organizations to provide these when you're developing your solutions and describing the story of why it will work. You also want to look to stakeholder input. You want to ask the constituents what they think. So drowning is a problem. Do we agree? Yes. Okay. Well, what are the potential solutions? What do you think if we did barriers around the swimming pools? Talk to swimming pool manufacturers, talk to real estate agents who sell houses with pools, talk to families who have had children who have been injured or died in that circumstance. Get their feedback on what they think will work. Talk to legislative aides about what they think would be feasible in terms of legislation. That would be really important to get a full view of what everyone thinks regarding the problem and your potential solution. And then finally, you want to educate the policy and decision makers. Now, as a public health professional, you may be wondering whether you can lobby, and certainly you can't unless you're a registered lobbyist, but there is a role to be played by public health professionals to advocate for the scientific approach to solving problems that have been measured systematically. So you can say, we found through science that the problem is X, Y, and Z, and we have potential solutions A, B, and C, and we think you should do that. So you can do that in a one-on-one basis. Go to their offices, set up meetings. Oftentimes they can be very brief. You might provide them with a one-page outline of what the problem is and what your recommended solutions would be. You cannot, as an advocate, recommend or speak on behalf of a particular law or act, that is, legislation that would become law, but rather you can speak to that legislation, or you can speak to that problem and those solutions more generally. So then once that window of opportunity opens and you're able to create legislation that passes, it's called enactment of that legislation. And in Florida, that certainly happened. It became the Florida bill in 2000 became, as I said, the Residential Swimming Pool Safety Act, called the Safety Act of 2000. Now that it is enacted, it goes into that second phase. The second phase under longest model is called the policy implementation phase. And this includes the rulemaking and then the implementation, also called the operation of that policy. So what it's saying here is that the laws in the legislative branch are passed, and then the executive branch takes over, and they implement the policy. All right? So that's the next phase. At this point, it's really important that I explain that there is a difference between laws and regulation. Now, generally speaking, they both carry the force of law. That is, you can still get in trouble, go to jail, be fined, whatever, for breaking regulations, but they are certainly different. Public health laws are the rules created for the protection of promotion of community health. They're made in the legislative branch. Regulations are the set of rules or policies that describe the implementation of legislation. Now again, this is the executive branch. That is, it goes from Congress to the president at the federal level, or it goes from the legislature to the governor at the state level. These regulations are more detailed than the laws. They certainly will describe potential fines, who will enact it, how much money will be applied or how allocated to certain areas. So it's much more details. A paragraph in law could be 100 pages in regulation. It's the implementation, it's the actual application of the laws, which are these regulations. Rules, regulations, ordinances, these are all sort of used in the same way. So once the policy is implemented, it becomes the law of the land, so to speak. It becomes something that can be enforced through policy. And as you can see, that circle on the right-hand side. At this point, in all policy, the cyclical nature becomes apparent because the policy then gets modified based on the feedback from individuals or organizations about how that policy is working. That is there a reduction in the problem that you created a solution for? So if you have a law and regulations that are designed to reduce drowning for children, didn't work, right? So this feedback can then you can find that there's limitation of the law or regulation. For example, 81% of all drowning occurs in pools that were regulated by pool fencing ordinances. That is, most of the time that law has already been in place, so there's something further that's needed. Inadequate enforcement of the ordinances and inadequate operation or maintenance of pool barrier equipment by owners may have reduced the effectiveness of pool fencing codes. Furthermore, who's checking compliance? Is it the public health department? Are there inspectors, home inspectors that go around? When does this happen? So what we realized, we had this great idea for a pool barrier to reduce drownings, but it only caught so many of the potential drownings. We think it works. There's some definite evidence to suggest that it does, but there's more needed. So how do we do that? Well, perhaps we create new regulation proposals or create a new law, but a regulation, you could say, inspect the pools at the time of the sale of property. So anytime a house with a pool gets sold, the inspector not only has to review the homestead, but also review the pool to make sure that the barrier is working. Or we say, okay, we're going to increase the fine to $1,000 if it's not working. So these are just some of the ideas that you could come up with to modify the policy so that it's more effective. So in summary, the policy-making process is just a 1, 2, 3 steps. It's a cyclical process of identifying a problem, creating solutions, and when a political circumstance lines up, called a window of opportunity, you can develop that legislation. Then it becomes law. The law must be implemented through regulations, rules, ordinances, to become policy. And that policy, of course, should be evaluated to make sure that it's actually working, whether it's doing something as it's intended or there's unintended consequences that need to be fixed. And so that could then develop new legislation, or you could go and develop new regulations, either way. So this is a cyclical policymaking process. All of it is informed by evidence, and you can use your knowledge and professional opinion and professional role as a public health professional to engage in policymaking, most certainly. So at this time, I'd like to move on to the program management section. Program management is also addressed in the Certified Public Health Exam Review Guide. This is Chapter 8, written by Sandra Pothoff, who has lots of experience with program management. The idea with program management is the implementation of the programs that are developed to protect the public's health. Program management session objectives include develop program or organizational budgets, that is with justification, implement a contract, program, or community health plan, sustain the workforce, the financing, and the programs, and then finally develop monitoring and evaluation frameworks to assess programs. And again, these are 4. There are more objectives that you'll find in the textbook, and I also would like to point you to the practice exams and the review guides on the website that Aaron pointed out at the top of this webinar. So first, budgeting. There are some terms that you should understand for the exam, and two of the most important are revenue and expenses. Those are not terribly complex concepts, but I tell you, you need to know some examples. When you see the exam questions, they may ask you, identify what kind of budget category would this fall into. And so for public health, providing services certainly generates revenue. Getting grants or investment income or donation, those are all things. Revenue means money coming in. Now, expenses, on the other hand, is the opposite, money going out. And the things you spend money on in public health include staffing, fringe benefits, supplies and equipment, rent, utilities, and little things like printing, postage, or maybe travel to around the community or to conferences, those sorts of things. When you're looking at expenses, you can actually divide examples of expense types into several types. There are two continuums here, direct and indirect, and variable and fixed. So there are really, in this chart, 4 types of expenses that you should know. Direct are those that are used for the delivery, the actual services themselves. Indirect are all the things that are not directly related to that product or service, but that are expenses. Then you have variable and fixed. Variable just means that it increases the more you deliver. So if you have a product or service, the more you do it, the more the costs go up. That's called variable. Then you have fixed costs. Those are just things that no matter how many of the thing you make, that's fixed, that's the same. So if you made 0, you'd have the same fixed cost if you made 100 million billion. Those are fixed costs. So you can have direct variable costs. An example of that are the supplies used for each unit of service provided, right? So if immunizations, I think, are a good example, right? So you have a syringe. Those are direct costs, expenses, because you're using it to deliver the immunization, that syringe, but it's variable. You use more every time you do the immunization, and the more and more are used, the more services you deliver. But you also have direct costs. So, for example, in that instance, you may have a medical assistant or a registered nurse delivering that immunization, but you have to pay for that nurse or that medical assistant no matter what, no matter if the immunizations are given or not. That's called a fixed cost. Because they get a salary, they're not paid for every shot they give. So that's a direct fixed cost. You also have indirect costs, and you often have heard those things called overhead. And that makes sense, I'm sure, to most of you. An example of fixed indirect would be maybe rent, insurance, management support. So if you maybe had a program manager, and within the program itself, you have multiple services that you provide, it would be indirectly allocated expense for that manager that's above all of those services. Then you could apply direct expenses to those actual services. So that's an example. You don't often see indirect variable costs, but I suppose you could have electricity maybe based on the basis of services provided. So maybe you have some sort of machine that needs to heat up, and it uses a lot of electricity every time you deliver that service. It's hard to, you usually don't have that, but that's an example of how you might have an indirect variable cost. So again, direct, indirect, variable, fixed, know those terms for the test. Use a note card and quiz yourself and try to identify examples. I think that will really solidify your learning there, using examples. Of course, staffing is a major expense category. You should be aware of 2 types of expenses associated with staffing. Of course, you have the full-time equivalent known as FTEs that you might include, and they probably get fringe benefits such as FICA, vacation, PTO, health insurance. But you might also have staff that are consultants or contract services. And those oftentimes don't have fringe benefits associated with it. Fringe, they're called fringe benefits for who knows what reason, but the idea is that they're the expenses associated with staff, with full-time staff in your programs or your organizations. You should know something called budget variance. So budget variance can be charted. And the idea of the variance is that when it's above or below what you estimate the program will cost. So let's say you have the program A is budgeted for $4,000, but it actually comes in at $2,000. What is the variance for program A? So again, you have a variance. Just means the difference in the budget between the budgeted and the actual, right? So if you have a consultant you thought was going to cost $4,000 for program A, but it actually cost $2,000, the answer to my question is the variance for program A is $2,000. $2,000 under. Now, program B also has a variance of $2,000. So you want to chart that. You see how it's over the budgeted for $2,000. It actually came in, the consultant, she was $4,000. So for program B, the variance is $2,000 over. So be aware of what a budget variance means. When you have budget variance for a particular program, you need to justify why that budget has changed. Oftentimes in your proposal or in your update, you're required to file paperwork and measures on how your program is being run, implemented, and operated. You need to justify why it changed. And all you do is you support the purpose and the goals of your program. It takes a little practice in the writing, but essentially you might say unexpected demand for program A led for us to shift the cost to program B, where unexpected demand required the allocation of consultancy for program B. So it's really just you justifying, or you saying, hey, this is why we did it, and it meets the goals and the purpose of the program. So you have to be very careful when you're doing that. Well, now we're into sort of management of public health. Now we're kind of in my wheelhouse on management. I teach a lot in management and strategy and implementation. And these are tools that you should be aware of and that will come up on the CPH exam because they're very common in our operation of public health programs. And I'll discuss each of them in turn so that you have a general awareness of what they are, and that you should then write them down and study them for recognition on the exam. Task lists and timelines, Gantt charts, flow charting are also called process flows, and then something called continuous quality improvement. And I'll review each in turn. Task lists and timelines are exactly what you think they are. Just all the things, the tasks, the to-do list that you need to do. In developing a program or even proposing one for a grant, you should develop the timeline that lists all the tasks out when they'll happen. A timeline is great because it shows in linear fashion when all the tasks are expected to be finished. You might also add milestones such as launched service or evaluation period to your timeline. So this is a great project management tool, really about visualization of how the program will work, what your stakeholders can expect. So know a task list and its associated timeline as a tool for program management. Also be aware of something a little more fancy, known as a Gantt chart. It's a little more fancy than a timeline, but it really is almost the same. It's named after actually a person, Gantt, who described this new kind of timeline that has some very interesting and specific features. The Gantt chart is used in project management, which is a real skill for running a public health program. Gantt charts have very specific features that I'd like to point out in this image and that you should be aware of for your exams. First are the project tasks. On the far left-hand side, those are all the things that have to be done. You might group them under certain objectives or phases of your project. You see that? Strategy, copy, layout, production. And those are just all under that kickoff meeting. Those are things that need to be done. The second thing that is a feature of a Gantt chart is the responsible party. You might say who. You have the what, now you have the who. In this, you list who is responsible for doing that task. You see John Lee and Pat Kelly, they all do those things. The other thing that's important to note about a Gantt chart is the duration. Duration can be put into a Gantt chart, and the number of days when it starts and when it ends. Gantt charts are known. The reason it's called a chart is because you graphically display. You can do this in Excel, and there's actually a Microsoft program called Project, but let's not get carried away. Your knowledge of these things, if you're not already aware, is important for you to recognize on the test. And what's interesting about the Gantt chart is it shows a graphical form of when these things are happening and each step and how they're related. So these are called dependencies. So again, Gantt chart is an important tool for project management. Another thing you should know for project implementation and for program management is something called flow charting or process flows. This is great to illustrate the steps required in a program. You might want to show the overall program, how it's all going to go into place as you propose it, or you may want to describe to your employees or your stakeholders the steps of a particular sub-process, and you want to show people. So a flowchart actually has its own language that really describes the steps. The shapes are, it turns out, very important, although you won't have to know that for the test. But flowchart, you should know that it's just a visualization of the steps in a process. I love a good process flow. And then finally, in this section, something you should know about is called continuous quality improvement. Well, we could have our own webinar on CQI. In fact, we just wrote a textbook on quality management. But I want to share this concept with you because when you're running a program, you're always seeking to improve. And in that, it's called CQI. You want to apply a certain methodology. And one methodology for continuous quality improvement is a cycle called the Plan, Do, Study, Act, PDSA, also called the Shewhart cycle, but let's not get carried away with that. The idea of CQI is when you identify something that needs to be changed and you plan to carry out something to change that. When you carry out the plan, it's called do. You implement that particular change to see if it worked, and then you study it, S. You analyze the data. Did it work like we expected it to? And then if it did, what you do is you act to either expand that change to the other parts of the organization or to another process or something like that. Or you might need to reevaluate and say, okay, we need to change it in some way because it didn't work like we quite expect. And then guess what? You start all over again with the plan, then the do, then the study, and the act. That's why it's called the continuous quality improvement. And there's lots of methodologies for doing this under CQI. You may have heard the terms Lean or Six Sigma, and those are really just fancy ways for doing this sort of scientific approach to quality improvement called the continuous quality improvement. So if you haven't heard of PDSA and its related concepts, that will probably be on the exam in terms of improving the quality of your program. A really important function these days especially, it's really hot, is ensuring sustainability. We oftentimes in public health have been really good at developing programs, but not so much at sustaining them. And according to the evaluation by APHA, looking at the workforce and asking them, this word sustain, it came up a lot. And the people working in the field understand that these are critical skills for public health professionals. Therefore, you will see it on the CPH exam. Ensuring sustainability. That includes the workforce, financing, and programs. And again, I will review each of those in turn, 1, 2, 3, in the slides that come next. First, workforce sustainability. We have to have the people that can do the work that we create. The experience where you get funding for a program to tackle a certain problem, and then we lack the workforce to implement it. or we lose someone, we have turnover, and we don't have them. This shows a lack of sustainability. So we can do some things to improve our workforce and make it more sustainable for our programs. First, there's an effort to professionalize the workforce. The CPH is one example. When we have a professional identity and we can recognize who reaches the competence for CPH, then that really bolsters and sustains our workforce. Education and training, whether at the university level or ongoing education at the organizational level, very important. Setting career progression paths is one way that we can sustain our workforce. We can't have just roles develop with no sight on where they could go. I know our students want to know how they can progress through the programs and throughout the organization. Having explicit conversations with your workforce about what the steps are to being promoted, where they can go, and embracing their development is really important. Furthermore, having clear job specifications, that is, describe the job description and the requirements for meeting that job meeting that job, in other words, being qualified to have that job, is really important. So defining it explicitly, not only in your job applications, but in their performance reviews is really important. And then finally, speaking of performance, giving constructive feedback about performance. This includes feedback on an ongoing basis, but also regular and formal feedback to the workforce on their performance. Having expectations for what they're supposed to be doing, the goals that they should accomplish, and then reviewing those goals, providing direction to the workforce about how they can better improve or to accomplish their goals is really important to sustaining and keeping your workforce. So financing sustainability is super important in public health. We oftentimes get programs funded. We don't have long-term sustainability plans for continuing the financing. So we as public health need to acknowledge the need for diversified and reliable long-term funding base for our programs. That requires oftentimes understanding that you have to have investments in various infrastructure and workforce development and have those funding mechanisms in place, as opposed to just always, doing 2-year cycles on various programs and then dismantling them when the funding dries up due to some political or unforeseen environmental force. I think that it also includes engaging in active financial planning, including understanding your costs and your revenues. So see above with the budgeting, knowing how much things are going to cost and how much money you'll need to sustain them is really important. So doing these financial statements, not only what your current operations show, but what the future holds potentially, and doing some planning that way. It's called developing pro formas. Those are financial statements for the future, which is very important. You need to strategize and prioritize your program within the existing government budget. So knowing what the government likely will pass as a budget and understanding from your organization's perspective which are the most important programs and those that could be that would be vulnerable to potential funding cuts, so that you don't have stress in your organization. You can maintain the most important programs, or you sustain them in the long term, no matter what the government funding process is. And then you really always need to be marketing, selling the effectiveness to funders and supporters about what your program is set out to do, how it's accomplished it, and how things have changed, and describing the future of sustainability for your program to those funders and supporters. A big part of sustaining programs with your funders and your supporters is describing the value proposition. We've done a very, I would say, weak job of describing to the government, legislators and regulators and funders of all types, the value proposition. Because frankly, public health has an incredible cost competitiveness versus medical interventions. we, an ounce of prevention is worth a pound of cure. So we know that. And there are various methods for communicating the value of public health programs. And I'd like to share these three with you in the next slide. Benchmarking, calculating something called return on investment, and then something called economic evaluation. And there are subtypes that you should be aware of for your test. First, benchmarking. When you benchmark, you use the best in class to compare. So you use a standard. A good example for public health is Healthy People 2020. You say, we're attempting to achieve X according to Healthy People 2020 goals, and we are now at Y. So we have a difference of whatever percentage, and we want to get there. And so then when your program reaches that benchmark, you can celebrate. So that's you saying there's a standard out there that we're not meeting, and we've got to do better. That's how we get there. So that's really important. Next is something called return on investment. Again, public health is really good at return on investment, especially when you compare ourselves to medical interventions. Return on investment is not terribly complicated in its math, but you definitely should memorize it so that you can understand the basics when you see it on an example. You're not going to do complicated math, no calculator needed, but you will have to understand how the concepts go. So I wouldn't be surprised if you saw these terms in various orders on the exam, and you'd have to identify where it goes. So return on investment is what we give, the things that we invest, that's our costs, and then the benefits, what it's worth, that's your return on investment. What we get in return is what the benefits are. So ROI equals the investment gain minus the investment cost over the investment cost. So what you're going to see is you have to multiply it by 100. So what you're going to see is a percentile. So for every dollar spent on immunizing children with the measles, mumps, rubella vaccine, it saves $16 in healthcare costs, right? So that's investment gain, that's 16 minus 1, the investment cost, times 100 equals a 1,500% return on investment. Wow. Very compelling. This slide, there's a lot going on here, and these are pretty complex terms. And so what my goal is for you today is that you understand that these exist, that these are called economic evaluations, and furthermore, that you understand that they're different. They mean something very specific. So we oftentimes use them interchangeably, and as a public health professional, one that is certified in public health, you should know that they're different, and you should be able to identify them. First, the cost-benefit analysis quantifies tangible and soft outcomes into a monetary number. All right. Cost-effectiveness analysis measures program outcomes in similar units, right? So you might say per life year saved, right? So you're not changing it into dollars, you're rather just saying relative effectiveness. This has this many life years saved versus that. Cost utility analysis often uses an outcome measure, standardizes the morbidity or mortality, often called a quality adjusted life year. That's a very common measure for cost utility. So again, cost benefit says, okay, it costs us this much to do it. Lives are actually, we spent this much to save 100 lives. Lives in general are worth $1 million, so we saved $100 million. That's how cost benefit works. You sort of assign value, monetary value to these outcomes that really is debatable on what you could assign dollar values to. But nonetheless, once you state your assumptions, you're good to go. And that's what cost benefit analysis is. Cost effectiveness is really about comparing and doing the number of years, life years saved for this intervention versus that intervention. And then finally, cost utility analysis. You'll see those very standardized metrics like quality adjusted life years. So know those, memorize them, be able to recognize them on the test. You'll be great. All right, in the last few minutes, I want to talk about this idea of developing and monitoring evaluation frameworks for assessing your programs. And above, I talked about continuous quality improvement. And this is, in large measure, that sort of thing, where it's continuous. You're identifying a particular standard, you're measuring how you perform, you're implementing some quality improvement intervention, and then you're reporting how you do. And then you continue to do that. Again, continuous quality improvement is a cycle, and that's how, over time, we continue to improve. If we don't then identify and hold these measures, hold ourselves accountable to these measures on a long-term basis, we can't improve the public's health. So let's discuss those each. First, performance standard setting is that idea of the benchmarking, is to knowing what we're trying to achieve. Oftentimes, funders will tell us what that is, or you'll tell the funder in a grant, we'd like to achieve X. Like going back to our policy discussion, we may say that there's a problem by defining the science and the evidence that problem exists, and say the benchmark is actually this, right? So Healthy People, again, is a really great place to start for that, because it provides us with measurable objectives. Healthy People 2020 are the performance standard for everyone in the nation. It then allows us to engage actors at the national, state, and local levels to take action to strengthen our policies. So when you're doing performance assessment and evaluation, you have to evaluate against a particular standard. And that's what's going on here. So you can find those Healthy People 2020 on the web, and there are dozens and dozens and dozens of measures. Next, you want to measure your performance. How are you performing in that particular measure? One more slide, Aaron. When you measure yourself, you need to then understand the difference between your performance, and the standard itself. So, for example, the county health rankings. You can go and look up where you are on these county rankings and county health rankings. For example, here is, on the next slide, adult smoking, the percentage of adults who are current smokers, right? So you can then find, let's say I'm in Sacramento County, I can find 13%, and that's above average, slightly above average. And I can also look up the Healthy People 2020 goal to know what that is. So you've got to know in performance ranking how you're doing, all right? So measurement is very important in assessment and evaluation. But once you know where you are, you've got to do quality improvement, and that is what I mentioned above, those cycles of planning, doing, studying, and acting, where you create interventions that are designed to improve that particular problem. You know what the standard is, what you try to get to, you know how you measure, and now you've got to do a quality improvement intervention. So, such as doing a tobacco cessation program. So you're going to figure out whether this works. You're going to, in the community, you're doing cessation programs, you're explaining it to your citizens, how to quit smoking, and then later you report on your progress. So that's the next step. Did it work? Sounds very much like science, and that's what it is. It's this idea of very practically applied scientific method. The short cycle plan, do, study, act is one way to do it, but there are a bunch. The idea, again, is you know what the standard is, you know how you perform, you then implement some sort of change, and then you report your progress, and you held accountable to it. We lowered smoking rates in our community by X%. that not only holds you accountable, but allows you to promote to the funders and legislators and the regulators and the people who donate to your organization that you're accomplishing what you set out to accomplish. It also holds you accountable for implementing things that actually work, so that you're measuring the outcomes of your programs in addition to all the good things you're doing. The number of tobacco cessation programs is good, but you really want to know, did they quit smoking? So that's why you do it. So with that, I'd like to thank you for attending today to the webinar. We made it in about an hour, which leaves us, if you're interested, a chance to ask some questions, and I'd be available to you.
Great. Thank you so much, Dr. Pruitt. Again, if you click on that orange box with the white arrow, that'll expand your control panel, and there's the question and answer box, and you can insert any questions you have for Dr. Pruitt on both sessions of his presentation today. While we're waiting for a couple questions to come in, Dr. Pruitt, do you want to just kind of give a little bit of advice? I know you did last week to the attendees, but in case some people weren't on the call, just about how to move forward with their studying, about the exam, what they can expect, just really any kind of guidance you can offer.
Yeah, I mean, I thought the exam was hard in the sense that I had to study. So I had a doctorate for a while before I took the exam. So it was sort of like, oh boy, I better go back and, review some of these things. When's the last time I looked at these concepts? And so I did just what you will probably expect. I got the books and I reviewed the study exams, the exam questions. I made note cards with concepts on them. I did a table of biostats terms. Okay, if I have this type of variable, I'll use this type of statistical test. And then, I generally have strong professional pride. In other words, I pay attention to public health stuff. I read the newspaper. I go to conferences. So all that sort of keeps me in the game, so to speak, being aware of these things. But then I took it and I was like, you know what? I know this stuff. And my impression of the exam is that if you're a competent public health professional, like you go to work and you feel good about the work you're doing, that you know what you're doing, you're going to do great. I would, though, study. That for me, just reviewing the information so I can feel confident going into the exam made all the difference in sort of my anxiety level, and I felt confident going into it, and it worked out great.
Great, thank you. There's a question about the QALY, and to go back to the slide,
Yeah.
I can do that.
That's a funny measure, the quality adjusted life year. It's under the cost utility slide. The idea of the quality is that it's adjusting for, it's not how long people live, it's how long they live a quality life. And that can be measured in various ways. So you want to basically make sure that people aren't just living a long time, but that their level of function is the same. And so what's called adjust it. And so it really is pretty technical. It's not something that I would do on the back of a napkin. But the idea is that you can then compare whether an intervention works. Now, I will say there's some detractors on the quality adjusted life years because it certainly favors those interventions that are applied to younger folks, so your pediatrics populations, because they live a longer time. So if you save a child from disability, they have a lot longer to live just naturally without a disability than if you were to apply the same intervention to the aged population, just because their lifespan is, they're at the end of their lifespan. So there's those complaints, especially if you want to compare quality for those two different populations. You know what I mean? But nonetheless, it is a way to sort of say we recognize that disability is just as important as lifespan, and so it adjusts for those things. I hope that's the answer to your question.
Okay, and then there's a couple questions about different links and such that were discussed within the presentation, and I'm going to post this final presentation on the website very shortly, so you'll be able to access all of those links once it's posted, as well as the recording of today's presentation. Let's see here. Here's from one person, and she says, I've taken both the old exam and the new exam. And to clarify, the old exam was structured in the 5 core areas of public health and the cross-cutting areas. And as of this year, the exam is structured in those 10 content areas with 10% in each area. And she says, I've missed it both times by a few points. I took all the courses years and years ago. I've made note cards and have the book. Any other tips you can provide her?
Well, if it's been a long time since you've taken those classes, it's probably been a long time since you've taken exams in general. And, this isn't news to you, but may need a refresher. Taking exams is just a very specific thing. So let me give you some tips on exam taking. When they're multiple choice, oftentimes there's 1 or 2 of them that are just not right. And so when you're doing that, you want to eliminate those immediately. And so then you may have a 50-50 chance, or a 1 in 3 chance at least to getting the right answer. And then it's about making your best guess from there. Oftentimes they're not trying to trick you. Rather, they're just trying to provide a framework for understanding your knowledge. So try not to overthink those questions when you're going forward. They're just trying to get a basic grasp. So my advice to you is, in the test taking, write down on your scratch piece of paper that they provide for you A, B, C, D, and mark it out physically on the piece of paper so that you can then not be overwhelmed with 5 or 6 choices, but rather 2 or 3. And then studying, I think the best way to do it is come up with examples, being able to apply the terms to an example. And the books that are out there have those vignettes and sample exam questions that really can help you apply the material. I think that's key.
Definitely. Here's a question. As far as health policy on the exam, were there other areas outside of the 3 steps that you covered on the exam?
Yes, there are. Health policy is quite complicated when it looks at, sort of how legislation is passed and those sorts of things. Those are covered in the CPH study guide. I just don't know how in-depth the new exam will be in those. I think if you understand at a general level the civics-related issues, then you should be good with understanding those. But knowing Medicare, Medicaid, knowing how the federal and the state governments work would be really important. But they're not going to ask you about particular laws necessarily outside of HIPAA, and that's related to something else. That's related to privacy. Those are ethical concepts.
And just to clarify as well, for the exam, it's going to be 4 answer choices, single best answer. There is no all of the above or all of the below except, that kind of question. They are single best choice answers. So, again, as Dr. Pruitt stated, if you can eliminate ones that you do know are wrong, and if it comes down to 2, just, go with your gut. And the questions are not meant to trick people. They really aren't. It is, if you recognize the terms and the procedures and the models and such, then that's going to be the single best answer. And again, if there's areas that you're not as strong in, the exam is equally weighted within the 10 content areas. So you can do very poorly on one of the content areas as long as you are strong in the other. So don't let one scare you. I know a lot of people get very nervous around all the biostats questions, but there are no calculations on the exam. You don't have to do anything. You just really need to recognize those theories and the models and, the type of calculations that you would need to do. So anything you want to add on that, Dr. Pruitt?
No, that's right. Yeah. I don't even think that, if you can understand go to the webinar on the biostats. If you're nervous about it, that'll be a really good webinar to attend, because my experience is they weren't advanced knowledge. It's really about sort of, do you understand sort of measurements and sorts of types of statistical tests that you would use as a consumer of research. Can you identify that information? I think that would be, don't get too intimidated. Again, they're looking for who's a competent public health professional, not who can develop a public health model, a statistical model.
Right. And there's a question about somebody didn't know that the exam had changed. And to clarify, it's really just the balance of questions. Before this year, it was 20% within the 5 core areas, and we had cross-cutting questions kind of sprinkled throughout. And now it is just equal within all those 10 content areas. So as we were discussed at the very onset, if you go to the nbphe.org website, you will see the content outline, and that's going to identify all of the 10 content areas as well as the different job tasks within each one. And if you go through that and you're good on several of the different content areas, but you need to focus on some of the others, it'll give you a little bit more insight on where you need to go. And then taking those free sample exam practice exams on the NBPHE website. And if you are one that has a little test anxiety or needs a little bit more practice, that's where the ASPPH study guide is going to come into play, because that we have over 400 questions now reflective of every single job task that is asked by qualified item writers that are really trying to all the content. So I would recommend you go there. And then also, again, the book that we've discussed that the fabulous faculty at South Florida wrote. If you need a little bit more in-depth content, definitely hit that. And I don't think there are any more questions. So with that, if you have any other questions, you can feel free to contact me, Erin Williams. I'm at ASPPH. It's williams@asppph.org. I can put you in contact with any of our presenters, Dr. Pruitt today, or any of our past presenters if you have a specific question. And thank you so much for your interest in getting certified. So have a great day.